last few years have seen us rely on frontline medical staff more than ever before, but as we travel through a winter of flus and colds and COVID, a doctor shortage means many people are struggling to secure an appointment. And according to a new report from the Australian Institute of Health and Welfare, almost half of us are living longer, but living with chronic health conditions. And that's not all. Doctors' groups are advising their members to ditch bulk billing, saying the Medicare rebate has long failed to keep up with costs. The Drum's David Taylor takes a look.
Medicare is the way the federal government most efficiently redistributes tax dollars back to the population when it needs healthcare.
Medicare was established actually in 1975 as Medibank, and then the second iteration of it was Medicare as we know it today, which commenced in 1984. And back then we didn't have the technological capabilities that we have now. We really couldn't have done anything much different in 1984, to be fair.
It helps fund a range of services like GP visits, blood tests and x-rays. GPs, for example, who bulk bill, agree to charge the Medicare schedule fee and are directly reimbursed by the government. But they don't have to. A doctor can set their own fee for service and still have part of their cost covered by Medicare. This is how it works. Let's say you see your GP for a standard consultation. If you're bulk billed, you'll never hand over a cent, but the GP is reimbursed by the government. Or you might pay $85 at the counter after the consultation. Then the patient, via the doctor's room or the Medicare office, claims the rebate. That rebate is currently set at $39.75. But a gap remains, which is the out-of-pocket cost for the patient. The key question now: is the Medicare rebate large enough for bulk billing practices? The rebate was frozen at $37.05 from 2014 to 2017, when it lifted to $37.60, adding an extra 55 cents. And this month, the Medicare rebate for a standard consultation increased from $39.10 to $39.75. It means GPs will receive an extra 65 cents for every bulk billed 20-minute appointment. But as with so many things, that increase of just 1.6% is well below the inflation rate of 5.1%. The Royal Australian College of General Practitioners says it's concerned GPs won't be able to cover rent, mortgage, building and medical insurance costs, as well as higher wages and the cost of highly sought-after supplies.
You've got to remember that Medicare does not pay doctors. So when you talk about pay rises, it actually doesn't apply to the Medicare scheme. The federal government has no constitutional authority to set doctors' fees. It does not employ doctors. It does not pay doctors. The Medicare rebate is the patient's rebate. So what Medicare does is reimburses the healthcare costs of Australians. It does not pay doctors.
But if GPs can't afford to wear the cost, can the patients, who'll end up paying for it in gap fees?
Yeah, bulk billing used to allow, Nikki, GPs to earn a good living, and we've just had an explanation that is no longer. So do we still have a universal free healthcare system?
No, because not everybody can access bulk billing. My GP just literally announced that they're no longer able to do bulk billing. And I was frankly shocked that they actually even offered it in my part of the world in the first place. I feel very sorry for them. And I think, we've got a big problem. I thought this when we brought Medicare in, that to have a universal system, I don't see what's wrong with means testing. It is so expensive. We saw this from the National Health System. Let people who can afford to pay for it, and that people who can't afford to pay for it have the support that they absolutely need. I think it's a very difficult situation. We've seen, obviously, if you make people pay for private health insurance, for example, they pay too much, then they don't want it, and it puts it all onto the public purse. So I'm not saying it's necessarily an easy economic equation, but what you ultimately have to do is to study to be a doctor. It's probably, I think, the most expensive course you can do at university. You would know.
Thank you for reminding me.
You have all this knowledge. People's lives are literally in your hands, and you obviously have to be recompensed. And I did have a look at what the sort of average income for a doctor is, and the range is is the lowest range is sort of where I had thought they were. I know a lot of people say doctors get paid too much. I actually thought they got paid too little from the GPs I know. They're certainly not living, driving around in Lamborghinis or anything, so I don't know who these are, people that... But the system has clearly got some challenges ahead, because if we're going to keep doing this and everyone needs to pay more, where does that money come from?
For more on this, we're joined by Sydney-based GP Dr Iman Joshi, who says that bulk billing is dead in the water. You seem to be suggesting, and indeed you quote in your article Karen Price, the head of the Royal Australian College of GPs, that the solution to getting the politicians to fix the system is to kind of hit the patient where it hurts, in the hip pocket, so that we have this conversation.
Look, I'm not trying to be difficult or inflammatory, but certainly what prompted me to say that in particular was just the fact that for the longest time, I think a lot of us GPs have been subsidising the actual cost of providing a good medical service for our patients, because we love them, we care about them, we have long-term relationships with them, and we want to do what's right for them. But in that process, what we're realising over the last few years, especially over the pandemic, is that most people don't actually understand how doctors get paid, specifically GPs, because it's the vast majority of us in the specialty that still continue to bulk bill, unlike the bulk of other healthcare workers. And what ends up happening is that we've been subsidising the cost, but as the introduction at the beginning shows, if the average cost of a standard good consultation is $85 and Medicare will only pay less than $40 off that, it literally means that in order for us to make enough to keep the practice running, pay our staff a decent wage, pay for computer confidentiality, all the other things, we actually need to either step up the number of people we see per hour, which then makes people unhappy because they feel like I'm being rushed. But it equally also means that we don't necessarily have the ability to provide the care that people expect and that we want to be able to give. And what that ends up doing is a lot of people end up thinking about leaving. And so I don't see what the solution is, because it's not going to hurt or affect change until it actually starts hurting, if that makes sense.
Amy, it's interesting. It seems to be that the funding was unsustainable. There was a freeze on the Medicare rebate from 2013 to 2018.
Yes.
And then the pandemic, I'll put this one to Amy, then the pandemic, all of it was just compounded by the pandemic and people going to the doctor much more often. Amy?
So I think there's a structural problem that accompanies this, which is that we do, like, how we run Medicare is fee for service, which incentivises volume, as Iman has said.
Yeah.
We're living in an ageing population of chronic conditions, and we need to be thinking about value-based care and how do we provide that. I think what's happened in the pandemic, and certainly what we're seeing in the hospital now, is that people can't get into their GP.
And you're working in a hospital?
I'm working in a hospital, unfortunately. And I can attest to the pressures on the system right now. They're very real. Like, I work in a regional area. We've been on code yellow, which is basically like the hospital can't take any more ambulances. We have no beds. This is happening all across the region. I work in a few hospitals. Every single one of them has been on code yellow at some point in the past few months. What's happening is we've stopped doing, over a period of years, elective surgeries, screening for cancers, things like this, whether people are just not coming or the services themselves were not available. Now we're getting an influx of people coming back into the system who need their chronic conditions looked after. They are now needing emergency surgery, and certainly, like in hospitals where I've been working, that's the bulk of what they're doing now, because that's all they can do, that's all they have capacity for. So we've got all these delayed kind of problems that we've kicked down the road that are now very acute. People are trying to go to the GP. I think people are trying to do the right thing. They can't get in.
Yeah.
If you're really unwell and someone says, sorry, you come in 6 weeks, not to mention you need a PCR before you can come into the premises. Like, I understand that there's a need for that, but it's another barrier. And then people come to the hospital because that's where they're like, I need care. The cost of that is ridiculous. So maybe it costs $85 to see a GP. It costs the system $500 every time someone comes into an emergency department. Yeah. Like, it makes no economic sense. Please tell me I'm right, Nikki.
You're absolutely right. Yeah. 85 is a lot less than 500.
I'm bang on. That medical degree was worth it.
It also affects the most vulnerable, and it affects people in terms of where they sit within the socioeconomic index, doesn't it, Pat? I mean, the more money you have in this country, the healthier you are likely to be. And if you've got to pay a gap fee at the GP, what does that do?
Yeah. Well, it's the most vulnerable Australians that are going to suffer from this if we don't get this sorted out. even with the Aboriginal community controlled health services that provide comprehensive primary health care to our patients, and we service over half of the Aboriginal and Torres Strait Islander population across Australia, we cannot operate on Medicare income alone. We have to have additional subsidy from governments to be able to provide the comprehensive primary healthcare model. But when we can do it fully, it is much more effective because A, we're seeing patients when they need to be seen as early as possible. We're doing the right screenings of the patients. We've got coordinated care programs for chronic patients and management of those patients. And quite frankly, our model of care should be available to every Australian, and it would save a lot of money. Too much emphasis on hospitals, and as Amy said, people not being able to afford to go and see a GP because they have to pay the full price and they'll only get reimbursed for less than half, maybe. People are making decisions now with the high cost of living between whether they see a doctor or they put food on the table for their kids or they pay the power bill. I mean, this is an outrageous situation. If we're going to have a universal healthcare system, let's have it and pay for the bloody thing.
Just a final question to you, Iman, just quickly if you can. Who would you bulk bill? Under what circumstances would you bulk bill? Just quickly.
So exactly as Pat has said, traditionally we bulk bill what we consider to be the most vulnerable and most disadvantaged groups. So just off the top of my head, a lot of Indigenous people, for example, people with severe, as in other groups, would be people with chronic complex medical conditions where they're pensioners or whatever it is, perhaps also people with chronic sort of addiction issues, severe mental health issues. These are all, chronic people, again, asylum seekers, refugees, people who are homeless. There's no way that any of us would charge any of these people. But at the end of the day, I think there's increasing dissatisfaction among us because we know that we just have to keep working harder and harder to pick up the slack for what the government hasn't been doing for all of us as patients who need to see someone in a timely fashion. When we actually provide that care with a trusted GP, it allows for lack of fragmentation of care. It allows you to have continuity of care to continue seeing that same person, especially if you have chronic diseases.